please, if you have any questions, comments, or any feedback at all, go ahead and type that into the questions panel on your GoToWebinar console. We do have a team here that's ready. They're monitoring the chat box, and they will try to get any answers to you as they can. You will also see that we do have some handouts available for all of you. We do have 3. 2 of these are the presentation slide decks for all of you to access and take with you after the webinar. And one is a sheet with information on IMO Anywhere. All attendees of today's webinar will be receiving a free trial of IMO Anywhere through September, so that's a bit of information for you. We will be providing the free trial information through the chat box as well as on the presentation handouts and in a follow-up email after the webinar. So don't worry, all of you will be getting your free trial and you'll get all that information soon. One last bit of information, we will have a small survey at the close of the webinar, so if all of you could take just a few brief moments to answer the questions, it'd be very helpful for all of us. So today we have June Braunert, Director of Terminology and Coding, as well as Teresa Rehanek, International Mapping Lead. So without any further ado, I'm going to pass it over to June.
Great, thank you. Hello everyone and welcome to the webinar today. We are going to walk through the additions and revisions of various systems with ICD-10. Specifically, we are going to talk about laterality content additions as well as classification changes for diabetes and Chapter 5 mental health, along with the ICD-10-CM fracture changes. And finally, we'll review CMS and the American Medical Association flexibility guidance. So let's get started with laterality. As you will see, there are increased laterality with the upcoming 2017 ICD-10-CM changes. Here's a few areas of examples, such as eye conditions, gynecological conditions, and along with the increased laterality throughout the system, there's additional spinal levels for certain disorders, as noted here with a specific example of the cervical disc disorder, that there were, in 2017, additional specificity with those levels. Now focusing on infectious disease, we'll look at the new codes. There is a new code, A92.5, coming for the Zika virus disease. There is also specific coding guidance with this the new code, and one is to code the confirmed diagnosis. So the A92.5 is the code for when the diagnosis has been confirmed. If the diagnosis is still suspected, the guidance is to code the reason for the encounter, such as fever or pain, along with a Z20.828 that identifies it's a suspected disease with exposure to. Another change in 2017 for the viral hepatitis is the carrier code Z22.5 has been deleted, and now the chronic viral hepatitis of B18 is assigned. So the idea of a healthy carrier is no longer in favor, and the chronic viral state is now the classification. We'll next look at neoplasms. And for neoplasms, there are additional codes, as you can see a few the examples listed here related to the gastrointestinal stromal tumor as well as the Cattleman's disease. And in addition, there are 2 codes added for hormones malignancy status, and it's the Z19.1 and Z19.2. And this identifies if the hormone malignancy is sensitive or resistant, and these were created with the prostate cancer treatments in mind. So we'll be able to add additional status codes with the Z codes for the hormone treatments. Turning now to ophthalmology. We'll see here again laterality was added, as well as additional specificity for the disease state as related to the retinal vascular occlusions. And you can see the disease states identify with macular edema or with the retinal neovascularization as well as stable. And stable is defined as that the disease is still present, but the edema is not present, and that there's no need for further treatment. So these are some changes to the retinal vascular occlusions to identify more specific information about the disease and the laterality. Continuing to focus on ophthalmology, we'll look at the age-related macular degeneration. Again, further specificity allowing for the stage and laterality for the different forms. And the codes are listed there for the new code, category codes of the H35s. We'll move now to the ear. And more specificity has been added. Here's an example of a few of those codes for hearing loss. And the new codes will allow for better reporting when the type of hearing loss is different for each ear. So again, when the hearing loss occurs, and there is a variety of types based on the ear, you'll notice that there's laterality and the different types are available now to report that. Another new code is the pulsate tinnitus, the H93.8, and this is a condition in which the patient hears a beating or pulse sound in their ears or head that is synchronous with their heartbeat. So you can see the changes that are listed on the screen related to the indexing to reflect these code changes. Next, we're going to focus on diabetic changes and complications, specifically focused on proliferative diabetic retinopathy. Again, the disease stages are further specified. As you can see here, there's 3 types of disease stages with codes, as well as laterality has been added. And the choices for the proliferative diabetic retinopathy laterality do include bilateral options, as well obviously as the left, right, and unspecified. And so when these conditions, there will be new selections when you're selecting through the modifiers to identify these stages and laterality. Looking at the macular edema complication, there is now codes for the various types. There's one example listed here on the screen, the E08.37X2, that identify resolved following treatment. Macular edema can reactivate after being treated, so the code descriptors now for the different types, which include type 1, type 2, and the drugs and chemical, will identify the state of the resolved following treatment. In addition to this information about the disease state, the laterality is added, and as well as new selections for the laterality and the diabetic macular edema resolved following treatment. The next slide will identify some other changes to diabetes in general with the recategorization classification. As you can see, the brittle diabetes and autoimmune will now be considered type 1 diabetes. And so one is directed to the codes for that type based upon the changes for 2017. And interesting enough, when IMO staff was reviewing the changes, they found conflicting information regarding diabetes in the control status. As you can see listed here is uncontrolled, poorly controlled, inadequately controlled, and out of control are various statuses that are indexed. And the index updated the index entry for uncontrolled diabetes, requiring the user to review and select hyperglycemia or hypoglycemia. However, the similar index entries for the inadequate, out of control, and poorly controlled were not updated and still defaulted to the hyperglycemic codes. So due to this review, IMO has sent a query to the ICD-10 Coordination and Maintenance Committee regarding this inconsistency, and we are still awaiting a response. And in the meantime, IMO is defaulting the uncontrolled diabetes to hyperglycemia while we monitor the status of our query. Next, we are going to turn our attention to Chapter 5, and specifically substance use disorders and the the changes that will occur in 2017. So the changes for substance use disorders relate to the reconceptualization of the substance use disorders. And so DSM-5 defines substance use disorders as a cluster of cognitive, behavioral, and physiological symptoms. And the substance use continues despite substance-related problems. And these conditions are seen in a spectrum from mild, moderate, to severe. So in order to better align DSM-5 and ICD-10-CM, in 2017 there are numerous index and tabular changes that occur in this area. And we're going to look on the next slide specifically at the cocaine-related disorders in that spectrum of classification. So as you can see, the substance use term for mild is closest approximation is abuse in ICD-10-CM language. So there are now index changes and tabular additions that actually state and include the use disorders. For example, as you can see on the screen, for the cocaine abuse, to mild is underneath the F14.10. And similar changes are reflected for moderate or severe substance use disorders. They will align to the dependence codes in ICD-10-CM. And so again, both the F14.20, cocaine dependence uncomplicated, contains both the moderate and severe terminology from DSM-5. So you'll want to pay attention to the indexing of the disorder of and the substance and follow that guidance, as well as review the tabular additions in order to ensure that the alignment is there with the use disorders. Another change related to new terminology with DSM-5 and alignment between ICD-10 and DSM-5 is in the neurocognitive disorder. Again, neurocognitive disorders are defined as a group of acquired disorders, and the cognitive function is the primary clinical deficit. Note, these are acquired and not development disorders, and these disorders also represent a decline from a prior functioning level. In DSM-4, the terminology was related to dementia and delirium. However, with DSM-5, the terminology is the neurocognitive disorders, broken out by major or mild. And currently in the 2016 edition, there is not an index entry for disorder neurocognitive. However, there are new index entries and tabular inclusions, which we'll look at on the next slide, that show the mild and moderate, how they will be reflected in ICD-10. Again, aligning these two, you can see the major neurocognitive disorder will be classified to either F01 or F02, depending upon the underlying etiology of the disorder, while mild will classify to G31.84. And you'll want to watch the excludes one notes underneath G31.84 to ensure that the appropriate code is being associated with the major or mild neurocognitive disorders. There's another area of alignment with DSM-5 and ICD-10 are related here to the depressive disorders and obsessive-compulsive disorders. As you can see, there are new codes that identify specific conditions, and these are conditions, again, that align with DSM-5. And we'll look at a few more on the next slide for further alignment, where binge eating disorder has a code, and there's additional codes, as you can see here, for the gender identity, persistent mood affective, as well as the social pragmatic communication disorders. So at this time, I'm going to turn it over to Teresa to talk about hypertension and a few other areas as they change for 2017.
Thank you, June, and I also would like to welcome you all to the presentation, and I'm going to start talking about the new category for hypertensive crisis, which was added at I-16. A hypertensive crisis occurs when blood pressure rises fast enough and high enough that it has the potential to cause damage to organs. The American Heart Association has defined hypertensive urgency as a systolic blood pressure greater than 180 or a diastolic pressure greater than 110 without associated progressive organ dysfunction. There may be associated severe headache, shortness of breath, nosebleeds, or severe anxiety, and immediate evaluation is needed for these patients. Hypertensive emergencies occur when blood pressure reaches levels that lead to impending or progressive organ damage. This usually involves blood pressure levels that exceed 180 systolic or 120 diastolic, and there is progressive organ damage. Some potential consequences of uncontrolled hypertensive emergency include stroke, loss of consciousness, memory loss, acute myocardial infarction, and others. So you can see the definitions on the American Heart Association's definitions for hypertensive urgency and emergency. This may be an area that you might want to review for physician documentation as part of clinical documentation improvement. And I'd also like to point out that malignant hypertension or accelerated hypertension still index to I-10, which is hypertensive. Another change in the cardiovascular section was I-69, where we now have, for cognitive sequela, added to the different types of cerebrovascular disease, subarachnoid hemorrhage, intracerebral or intracranial hemorrhage, and cerebral infarction. There are codes added to capture the various types of cognitive deficit that I have listed here on this slide. Other changes were additions of codes to specify other sites of aneurysm. So I-72.5 captures aneurysm of other precerebral arteries, such as the basilar artery. I-72.6 is vertebral arteries. And then you see we have new codes at I-77.7 to capture other precerebral and then specific extremity sites. An important indexing change is related to stable angina. You'll see in the middle of the slide where I have the addenda changes that angina was changed from I-20.9, which is unspecified angina, to I-20.8, which is other forms of angina. You'll see in the tabular excerpt I have there that stable angina is now listed as an includes note. And this will be important to keep in mind when you're coding arteriosclerosis of a coronary artery at I-2511 or I-25.7, that the combination code you are using for stable angina will be the one that represents other forms of angina. Another indexing change is that systolic murmur has been changed from directing you to see endocarditis to go to R01.1, cardiac murmur unspecified, in the signs and symptoms chapter, but diastolic murmur still remains with the directive to see endocarditis. In the digestive system, we had several changes related to the teeth. We have new codes for pulpitis, or reversible or irreversible. Reversible pulpitis is once the pulp is still considered to be vital, so once that irritant's removed and the restoration is done, the pulp can return to a normal, healthy state. But irreversible, that tissue is not going to return to a healthy state, and treatment usually involves extraction or other endodontic treatment. The acute or chronic periodontitis was expanded to capture localized versus generalized and the severity. A localized periodontitis is when less than 30% of the teeth are involved in the disease, and if it's greater than 30% of the teeth, then it's generalized. As for severity, that is determined based upon clinical attachment loss, either for the entire dentition or for individual teeth. We also have a new code for horizontal alveolar bone loss and the two types of occlusal trauma. These were requested due to the frequency of these conditions in active practice. We have a new code for food protein-induced enterocolitis syndrome, which is a gastrointestinal food allergy that typically causes vomiting 1 to 3 hours after eating the causative food. And later there may be severe diarrhea that the vomiting and diarrhea can lead to dehydration. This typically occurs in infants with onset before 3 months of age, but up to a year, and it typically resolves after the child has reached 3 years of age. Typically, this condition is most often induced by milk or soy proteins, and the elimination of that causative food from the diet is how it's treated. Another type of food protein-induced enteropathy is classified at K52.22, and it's a type of non-IgE-mediated food allergy that also occurs in young infants and causes chronic diarrhea, weight loss, and failure to thrive. And it's also treated with dietary elimination of the allergen. Indeterminate colitis is captured at K52.3. This is not the same as unspecified colitis. Indeterminate colitis refers to inflammatory bowel disease with colitis in which neither Crohn's nor ulcerative colitis can be diagnosed. Another clinical term for this is colonic inflammatory bowel disease unspecified, or CIBDU. Around half of patients that are initially diagnosed with indeterminate colitis may subsequently be diagnosed with Crohn's or ulcerative colitis, but there's a significant number of patients that this does not happen. We also have new codes expanded in the microscopic colitis subcategory to capture collagenous, lymphocytic, other, and unspecified. At K55, there was quite a bit of expansion to further allow coders to differentiate the site of the infarction or ischemia, whether it's small bowel or large bowel or unspecified, and then it's based on whether it's ischemia or infarction, and then you can further delineate between focal or diffuse. And you'll also see that we do have a code for unspecified if it's not stated to be focal or diffuse. We have a new code for necrotizing enterocolitis, which is characterized by damage to the intestine that can lead to related to inflammation, infection, or ischemia, and it can lead to necrosis, which can cause perforation and death. So due to its potential severity, necrotizing enterocolitis is considered a medical emergency. We have codes at K55, 0, 3, 1, 3, 2, and 3, 3 to capture unspecified, and then stage 1 through 3. While necrotizing enterocolitis is most commonly seen in premature infants, the condition can occur in term infants and infants outside the newborn period, as well as occasionally in adults. And so the new codes allow us to capture specificity in capturing necrotizing enterocolitis when it occurs outside the newborn period. So keep in mind that if it's a newborn, you will still classify it to the codes at P77, but if it's outside the newborn period, you would use K55.3. We have new codes related to constipation. In irritable bowel syndrome, we already have existing codes that differentiated between with diarrhea and without diarrhea, but they have now added a new code for irritable bowel syndrome with constipation at K58.2, and mixed irritable bowel syndrome, which is when there's the presence of both diarrhea and constipation. We have new codes for drug-induced constipation at K59.03. There is a use additional note to identify the adverse effect of the applicable drug. And we have a code for chronic idiopathic constipation, which is also known as functional constipation, at K59.04. At K59.3, megacolon was expanded so we can capture toxic megacolon, and toxic megacolon is a form of acute colitis, toxic colitis that can be potentially lethal, and it's caused by quite a number of different things, such as inflammatory colitis or Crohn's, or an infection such as salmonella, or even radiation or an adverse effect to chemotherapy. So we do have a code first note present at K59.3 to tell us to code the toxic agent if applicable. Acute pancreatitis was expanded, so throughout all of the different types of acute pancreatitis, so we can now capture without necrosis or infection, with an uninfected necrosis, and with infected necrosis. So those codes will be helpful to identify the severity of the pancreatic pancreatitis. We have a new code also for exocrine pancreatic insufficiency, which involves problems with the production of pancreatic enzymes needed for digestion. And it's typically seen with a number of different patient populations, with the two most common being chronic pancreatitis and cystic fibrosis. So throughout the tabular, you'll see other code also notes where at like C25, which is malignant neoplasm or pancreas, or at E84, cystic fibrosis, to remind you to also code the exocrine pancreatic insufficiency if it's documented. Gluten is a protein complex found in wheat and other grains, and I'm sure all of you are familiar with gluten-free, the cereals and that kind of thing. So celiac disease is the best known type of reaction to gluten exposure, and that's an autoimmune disease with findings that can range from intestinal symptoms of diarrhea, weight loss, to systemic problems. So the term gluten sensitivity was previously used essentially as a synonym for celiac disease. However, it has more recently come to refer to gluten reaction that may have symptoms similar to celiac disease, but where the autoimmune criteria for celiac disease is negative. So in light of this information, non-celiac gluten insufficiency now has a unique code at K9041, which separates it from celiac disease, which is classified at K90.0. Some other miscellaneous additions, you'll see that we have in the metabolic chapter unique codes to differentiate familial hypercholesterolemia from other types, which will be classified at E780. Familial hypercholesterolemia is a common autosomal dominant genetic disease, and we also have a corresponding family history code which was added to track patients that have relatives with familial hypercholesterolemia. We have new codes for multifocal motor neuropathy, periorbital cellulitis, a new code for excessive and redundant skin and subcutaneous tissue at L98.7, which is typically used for patients that have excess skin following massive weight loss or a gastric bypass surgery. That excess skin and subcutaneous tissue can cause a variety of medical problems, and so we can capture that kind of information with this new code. Moving into the musculoskeletal chapter, we have a new category to capture autoinflammatory syndromes at M04. The autoinflammatory syndromes are a group of recently understood disorders which involve problems with the immune system regulation with manifestations related to systemic inflammation. These disorders generally involve recurrent episodes of fever, rash, with lymphadenopathy and musculoskeletal involvement. So you'll see from that tabular snapshot on the side, a variety of diseases and syndromes are classified to these subcategories. So some conditions have been reclassified due to M04 being created. So familial Mediterranean fever is an example where it was reclassified from E85.0, which was amyloidosis, to M04.1, and familial cold urticaria from L50.2 to M04.2. Other changes in the musculoskeletal section, we have codes now for bunion and bunionette with laterality, pain in the joints of hand, and as June mentioned earlier, the cervical disc disorders at M50, now you can capture the mid-cervical region by level. And we have a new code for sarcopenia at M6284. Sarcopenia was originally referred to the loss of muscle mass that occurred with age and was seen as a characteristic state almost universal with aging, but over time clinical perspective has evolved, and it's now defined as a combination of low muscle mass together with weakness causing functional problems. So in light of the changing and the understanding of the diagnosis, we now have a new code for that. Another indexing change in the musculoskeletal chapter, you'll see for gouty arthritis, arthropathy, bursitis, neuritis, so forth, that the index used to direct us to see gout idiopathic, and now it directs us to gout. So unless the gout is further specified in the documentation, you're going to end up at M10.9. I'll turn it back over to June to talk about atypical femoral fractures.
Great, thank you. So as you can see on the screen, atypical femoral fractures is a specific type of fracture. And the request for a new code was submitted due to the increased diagnosing frequency of the specific type of fracture. So as you can see, there is the code M84.75, and then the applicable seventh characters ranging from an initial encounter to a sequela are available, and there's an example at the underneath that of the right leg of an incomplete. So let's look at the actual clinical characteristics that define an atypical femoral fracture. As you can see, they range from a very specific site where it's located to the periosteal reaction of the lateral cortex. So the characteristics that are bulleted here are are present for the fracture to be defined as the atypical femoral fracture regardless of the types. And what's interesting as well to note is in association with the bisphosphonates and other medications such as the glucocorticoids are also part of the defining characteristics for these fracture types. And so there in the next slide we'll see, in addition to the atypical femoral fractures, they are considered to be complete, incomplete, or unspecified. And so additional information about what defines a complete atypical femoral fracture, incomplete, and unspecified. So you can see that the complete extends across both cortices, a medial spike is present, and then the orientation is transverse or a short oblique for the fracture to be complete. Incomplete only involves the lateral cortex, again the M84 code with the example for the code descriptor, and then there's also an unspecified, so if it is unknown the type of fracture at the time of the encounter, there is a code for the M84. Let's look at another type of fracture, the periprosthetic. Currently in 2016, these fractures are classified in the complications section. Well, starting in 2017, the fractures will be classified in the musculoskeletal. They'll move to the M section, as these are fractures that occur around the prosthesis, not actually of the prosthesis itself. So you can see the excludes notes direct you one to another location if the information is more about diagnosis, the breakage of the prosthesis versus the actual bone around the prosthesis. And so on the next slide, we'll see some of the common locations of where there's codes for, along with the 7 characters. In the hips, knees, ankles, shoulders, and elbows are the most common locations, and again, the 7th characters identify initial, subsequent, and sequela for the encounter type. And so the following slide for M97 shows some of those common sites along with the descriptor. So it's important to keep in mind that these fractures are around that internal prosthesis, not actually of that prosthesis. So M97.11, M97.12 identify for the knee, and you can select laterality. And so, and of course, there's a 0.8 for the other if there's not a specific code descriptor identifying the specific prosthetic joint area. So keep in mind those codes move out of the complication and are reclassified into the musculoskeletal. We'll turn our attention to urinary and look at some of the changes in urinary. So the first change was a revision in the title to code N10 to reflect common terminology used in the United States of acute pyelonephritis. Another change for the urinary section was the expanded codes for the dysplasia of the prostate, and you can see there how they were expanded, and additional specificity was added for other disorders of male genitalia as well. And finally, with the erectile dysfunction, the reasons for erectile dysfunction that occur due to less invasive procedures, there are 3 new codes added in the N52, 35, 36, and 37 to identify reasons that the ED occurs but by less invasive procedures. Again, increased specificity in selected areas. Continuing on with urinary signs and symptoms, there is a new code, the R31.21, for asymptomatic microscopic hematuria. So there is additional specificity in the area related to difficulties with micturition, and you can see that additional specificity on the screen with the expansion of R39. Another important reclassification is related to bacteria. In 2017, this diagnosis moves to the abnormal findings of the R8271. It has been reclassified from the N39.0. And N39.0 is the code for a urinary tract infection. So keep in mind that bacteria is now going to be classified under the abnormal findings of the R8271. And another change in urinary signs and symptoms is related to the monitoring of PSA following treatment of prostate cancer. There is a new code that is added, as you can see, R97.21 of the rising PSA following treatment for malignant neoplasm. And this was added to identify when PSA increases during the PSA monitoring for prostate cancer that is considered cured. So that's important to keep in mind that there is now a code to reflect that state of following the treatment and the PSA is rising. And now turn it back to Teresa to review obstetrics.
Thank you, Jim. So codes within 000 are pregnancy with abortive outcomes that capture ectopic, abdominal, ovarian, and tubal pregnancies, and they have been expanded to differentiate between those that do have an intrauterine pregnancy and those that do not have an intrauterine pregnancy. At CAT 009.1, the title was changed from supervision of pregnancy with history of ectopic or molar pregnancy to supervision of pregnancy with history of ectopic pregnancy only, and then they added 009.A that captures the supervision with the history of a molar pregnancy. So if you're doing any data digging from 2016 and you want to compare it to 2017, you'll have to remember that 009.1 in 2016 represented a history that could include both ectopic and molar, and then 2017 forward, it only represents ectopic. In categories 011, 12, 13, 14, and 16, they did some cleanup and added complicating childbirth and complicating the purparium options. Previously, those codes were we only had codes for the trimester options. Within 024.4, gestational diabetes mellitus category, we have a new code added to capture gestational diabetes controlled by oral hypoglycemic drug. Previously, we only had options for diet-controlled and insulin-controlled. And we also have a new code, Z7984, which is long-term use of oral hypoglycemic. And you do not need to use that code if you're using the gestational diabetes code controlled by oral hypoglycemic drug. A little bit more cleanup was done at 033.7 for maternal care for disproportion. They added a 7th character to identify the fetus number involved in that complication. And then for maternal care for uterine scar from previous cesarean delivery, we now can capture what the type of scar, whether it's low transverse, vertical, and then we still have an unspecified option. The American Congress of Obstetricians and Gynecologists, ACOG, requested an expansion within category 044 to allow for differentiation between complete placenta previa, partial placenta previa, and low-lying placenta. So placenta previa occurs when some portion of the placenta is covering the internal cervical os. So when it's complete, the entire cervical os is covered, and partial, only part of it's covered. Both of these conditions may result in hemorrhage, and both require close monitoring, often requiring a delivery by C-section. And then low-lying placenta is a condition where the placenta implants low in the uterus but does not cover the cervix, and so that requires less follow-up. So at 044.0, you'll see that the title changed from placenta previa specified to complete placenta previa. And so you'll want to keep track of that if you're doing any data digging between 2016 and 2017 forward. Also, I wanted to mention that indexing directs users to default to the without hemorrhage code, and we do have a separate subterm available to direct to with hemorrhage codes when that hemorrhage is documented. ACOG also, through its collaborative hub, the Women's Health Registry Alliance, helped develop the following definitions for the 3rd and 4th degree perineal lacerations in hopes that it would promote more consistent documentation of lacerations for quality improvement. So they've published the revitalized definition on their website as well. The code expansion was requested for 3rd degree perineal lacerations to capture the specific grade of laceration, whether 3A, 3B, or 3C. And there's also an unspecified 3rd degree perineal laceration code option at 070.2. So this is a potential area to monitor for documentation improvement. We also have a new code for gestational carrier or surrogates, as this is becoming a more common practice. So Z31.7 is to be used when the patient presents for procreative management or counseling as a surrogate, or Z33.3 can be used to capture the surrogacy state with other obstetric complication codes. More specificity was also added for encounters for initial prescriptions or surveillance of various contraceptive methods, including vaginal ring, transdermal patch, and implantable subdermal contraceptives. We see a few other indexing changes that reclassify bicornate uterus in pregnancy from O3459, which is maternal care for other abnormalities of gravid uterus, to O340, which is maternal care for congenital malformation of uterus. And then postpartum hypopituitarism codes to O99-285, which is the endocrine, nutritional, and metabolic disease complicating the puerperium. And you'll have to remember to also assign the use additional note directs you to assign the condition, so we'll pick up E230 to reflect the hypopituitarism as a specific disease. In the newborn chapter, many coders will be happy to have codes for Z05, observation and evaluation of newborn for suspected condition ruled out. So these are our V29 codes that we had in ICD 9CM and didn't have this year in 2016. The proposal took several refinements before it was published, and the instructional note present at P00 to P04 is reflective of the changes to the codes present in these categories. P00 to P04 are not to be used for conditions that were suspected and subsequently ruled out. Rather, use the codes from Z05 to capture these conditions. You'll notice that the non-essential modifier suspected to be was removed from code titles in P00 to P04. And this proposal was brought forth by the American Academy of Pediatrics, as they felt it was necessary that we be able to capture suspected conditions that were ruled out as a reason for the encounter, as it's really not uncommon for parents to seek care for a perceived problem with their child. And the other change we see in newborn is low birth weight. Newborn of light for gestational age or small for gestational age, we now have codes to capture when that baby is 2,500 grams or greater. In the congenital malformations chapter, you see there was significant expansion of congenital malformation codes specific to the aortic arch and the aorta. We have expansion of codes to identify obstructing, non-obstructing, and microperforate longitudinal vaginal septum, as well as the site of the anomaly. And a little more cleanup was requested to differentiate between a congenital metatarsus primus varus and metatarsus abductus. We also have a new code for congenital sacral dimple. A sacral dimple is an indentation present at birth in the skin on the lower back. It's relatively common for neonates that may be benign in nature, but they could, if accompanied by a nearby tuft of hair or certain types of skin discoloration, indicate a more serious health issue like spina bifida or tethered cord syndrome. So parasacral dimple has now been reclassified to Q82.6 instead of L05.0 for pilonidal cyst. We also have a new code for arterial tortuosity syndrome, which is a rare genetic connective tissue disorder. And on to the scores. We have a new code category to identify codes for the National Institutes of Health Stroke Scale, which is a systematic assessment tool to evaluate and document neurological status and stroke severity. The assessment tool is a 15-item exam that measures the patient's clinical status in areas including level of consciousness, facial palsy, best gaze, motor skills, limb ataxia, language, and visual fields. A certain number of points are given for each impairment, and a maximum score of 42 represents the most severe and devastating score. This scale has been shown to predict mortality in acute ischemic stroke patients in several studies, and its use is supported by evidence-based guidelines. So there was a large contingent of respected societies and associations that requested the creation of these codes, and these codes are to be used for when they're measured on the initial patient evaluation. And so we have 42 codes that were added to represent the stroke scale. There we had an instruction at R40.2, comma, to add the seventh character to R40.21, 22, and 23 to describe the time when the Glasgow Coma Scale test was administered. But that same instruction did not exist for R40.24. And so they did add that, so we have the seventh character now to identify the location, which wasn't previously available in 2016. And one other little note in signs and symptoms, if you have adult respiratory distress or child respiratory distress not specified as syndrome, the index was corrected to identify that as R0600 for unspecified dyspnea instead of J80 respiratory distress syndrome. And I'll turn it back over to June.
Thank you. We're going to talk about another fracture, the physial or Salter-Harris as they are classified into. So these are fractures through the growth plate. And so for growing young people, there were additional sites added to this set of fractures, the calcaneus, metatarsal, and toe. And so these additional sites will be available at have the selection of the Salter-Harris type and the modifiers for the metatarsal, calcaneus, and toe. And so on the next slide, we'll look at some of the specific types of the Salter-Harris, as well as a couple examples of the codes that show their types range from type 1 to other and unspecified. And so there are the clinical criteria for the various types, such as type 1 follows the growth plate, and type 1 and type 2 typically do not require surgical intervention, and type 2 goes through the growth plate and the metaphysis, but does not affect the epiphysis. Excuse me. So type 3, surgery is often required, and for type 4, surgery may be needed, while the other is less common, and then there is the unspecified type of the physial fracture. And so the codes that for the metatarsal, the calcaneus, and the toe now are available to be specifically identified with new codes for 2017. Looking at complications areas next, there is additional information that has been added to allow for additional details for data analysis and the granularity and specificity. So for example, for the neurostimulator systems, the existing codes have been revised and the new code has been added to differentiate between the electrode lead and the generator. There are also new complication codes across various complications to identify the intrathecal infusion pumps, and specifically to the genital urinary section regarding urinary stoma complications with the N99.5. Their stomas are now identified by incontinent or continent. And so an incontinent stoma is one that drains continuously to an external appliance that is periodically emptied, while a continent stoma is one where urine accumulates in an internal pouch that is periodically emptied by inserting a catheter. And so again, there's the differentiation between the continent and the incontinent, and then what is the specific complication, such as the herniation or the stenosis or fibrosis. So those are available for more detailed information. And then continuing on with the urinary catheters and devices, there were revisions intended to incorporate the appropriate terminology and current urological medical malpractice or medical practices. So there are, again, revisions to this area with the catheters that are identified, and as well as the devices for the stents are placed under the devices and implants to identify that. And then the next slide shows the types of complications, such as the breakdowns, the leakage, displacement, and there are also new codes for the graft erosions or exposure. You can see here with the T83 identifies various types of complications of the urinary section. additional complications now focused more vascular is stent stenosis. So it is common occurrence in the body's natural response to have stenosis occur at a later time inside a stent, whether that stent is placed in the coronary artery or in a peripheral vascular stent. So this is typically called in-stent stenosis or restenosis. And now there are specific codes, as you can see, T82.855 identifies the coronary arteries, while T82.856 identifies the peripheral vascular arteries stents that can be associated to track this in-stent or restenosis conditions. And then T82.857 is for the other cardiac prosthetic devices, implants, and grafts. Another change to the complication sections were related to hematoma and hemorrhage. And so there are clinical differences between post-procedural hemorrhage and hematoma that necessitate different care types. And so in order to have the different care types and indicate each condition, these conditions in 2017 will have their own codes in this. As you can see, some of the examples of the post-procedural hematomas that are throughout the code system that they now will identify hematoma only or the hemorrhage only or seroma. And so a postoperative hemorrhage indicates ongoing bleeding, and urgent surgical intervention is required for the postoperative hemorrhage, whereas a postoperative hematoma indicates the bleeding has stopped, and a post-op seroma is the clear fluid. So now there will be individual codes instead of the combination code descriptors available to identify was the condition a hemorrhage or a hematoma. Some other areas turning our attention now to external causes of where there was cleanup in the classification is the sports utility vehicle accidents. There was some revisions to have that for consistency throughout, and you can see which codes were deleted and the new codes here on the screen. A new activity code, Y93.85, was added for the choking game. It also may be known as the pass-out game, feigning game, and blackout game. And this is an activity amongst children and adolescents involving choking themselves or others. They use hands or a noose or another article of clothing such as a scarf or belt. And this choking may produce a brief euphoria or high, which could be related to the hypoxia. So there is an external cause code to identify that activity which may be reported. Another reclassification of external causes is related to the sharp objects. And as you can see, there are moving some of the codes from W45 to W26 and just working to clean up the classification system as related to the different sharp objects. In 2017, we have a new code for overexertion and strenuous movement, the X50. And as you can see, there's additional details as far as what is the specific type. The strenuous movement or the repetitive movement have their own codes to identify how the injury or issue has occurred along the way. And so these will be able to capture what we used to capture in ICD-9-CM with E927. And then looking at the factors influencing health status, there are some new category codes with the Z29, as well as procedures converted to open now has a code with the Z53. And the long-term use of oral hypoglycemic drug that Teresa had mentioned earlier, Z7984, is available in addition to the personal history of unattended awareness under general anesthetic. So the Z9284 has a code that can be captured to identify that personal history. And then finally, for other post-procedural states, in addition to the other, there is now a history of a uterine scar from a previous surgery with Z98. 1.891, and this was requested by ACOG for this new code to identify that state. And those are the those are the code changes for 2017 from 2016. And as you may be aware of, we have been in the code freeze because of ICD-10 implementation. And starting this October 1st, we will be coming out of that code freeze, and then these are the changes that will be implemented. But I also wanted to note the CMS and the AMA's flexibility guidance statement. And so this is a statement that was actually released in July 2015, and the goal of the statement was allowing the medical community to gain experience using the ICD-10 code set. And as you can see here, the guidance was the 12 months after implementation from the carriers that the providers would not who were billing under Part B would not be denied solely based on a specificity of an ICD-10 code, as long as they were using a valid code from the appropriate code family, which was further defined through a series of clarifying questions and answers for where the right family code had to be within those categories that kind of where we talked about. So if it was a fracture of an atypical femoral fracture, that you use the code, the appropriate code for that, which now, and then not a fracture of the elbow or the humerus. So obviously with 12 months approaching on that, and that was to start October 1st, 2015, and occurring to 2016, there have been a question that was just recently, as of yesterday, posted to an update to their clarifying questions and answers on CMS's website. And this is related to unspecified codes, and will they be allowed once the ICD-10 flexibility expires? And the answer to this question is yes. And CMS goes on to further explain, and it is consistent with the coding guidelines, that unspecified codes have an acceptable and even necessary use. And so if the information is not known at the time of the encounter, it would not be appropriate to code a more specific code. So one is directed to code at each health encounter to the level of certainty known for that encounter. And so there is a slide that we have available for resources that you also have in your handout, that you can see more information about the topics that we have presented, from the Coordination and Maintenance Committee to the specific code set 2017 release, as well as information about the flexibility guidance between CMS and AMA, and that you would be able to find that updates to clarifying questions, and that shows that unspecified codes have an appropriate place, because there are just times clinically that is all the provider knows, and in various sections, and those are appropriate codes. So with that, I'd like to turn the presentation back over to Laura, and thank you.
Thanks, June, and that wraps it up for about all we have time for. I would just like to urge everybody before you leave to grab the handouts that we have provided. There is additional information, like you should be seeing on my screen right now, for contact information for both June and Teresa, who were talking to you today, as well as information for our sales team, customer support, and how you can access the recording of this webinar on our affiliates page. We will also be offering another session for this webinar. This was we had such good feedback for this webinar, so we added another session on for next week. This information will be sent to all of you in a follow-up email, so keep your eyes out for that this afternoon. You will have the opportunity to pass this registration link on to others if you think they would be interested. I have also posted into the chat box all of this information that is on your screen right now to get your free trial of IMO Anywhere for attending today's presentation. I will leave this up for a few more moments. All this information is in the handouts that we have provided for you, so if you haven't grabbed them, please go ahead and do that now, and it will all be in the follow-up emails this afternoon. So again, thank you all for joining us today. If we don't see you again next week, we hope to see some of your colleagues, and we're happy you could join us today. Thanks.